Well, good morning, everyone. Welcome to the Health Services Research Center Distinguished Speaker Series. Before we start, just a few housekeeping notes. This webinar is being recorded and will be available to view on our website. Please mute your microphones throughout the presentation. If you need any technical assistance, please contact the RNA team. We have Nicole Bollinger and Abigail Zona Patel on the call. If you'd like to ask any questions to our speaker, you can type them in the Q&A box. Make sure that you type them in the Q&A box and not in the chat window. Questions can be seen by all attendees, and you'll have the option to submit anonymously if you prefer. And for those of you who are invited to the meet and greet session, please remain on the Zoom upon the completion of the Q&A part. With that, it's my absolute pleasure to introduce Dr. Dilan Ellgala, who's a board-certified neurosurgeon, co-director of Barrow Global, and professor of neurosurgery at Barrow Neurological Institute. He completed his neurosurgery residency at the University of Virginia, spent a year abroad at Auckland Hospital in New Zealand, and then completed a cerebrovascular fellowship at Brigham and Women's Hospital in Boston. His neurosurgical expertise is in complex brain surgery and leveraging new technology to advance brain and spine care. He is well known for advancing global neurosurgery, and that's how I got introduced to him. Recognizing an unmet need for medical education in rural areas of Africa, Dr. Ellegala founded Medactory Africa, a nonprofit organization to improve the healthcare of sub-Saharan Africa by facilitating local medical training and education. As an early career faculty, he was the founding dean of the Center for Global Health at the Medical University of South Carolina. Dr. Ellegala's groundbreaking work in global neurosurgery development is documented in a book called A Surgeon in the Village. An American doctor teaches brain surgery in Africa by Pulitzer-nominated journalist Tony Bartlam. That was one of the books that truly inspired me to pursue a career in global health and the type of work I wanted to do in this field. So as you can imagine, I'm beyond thrilled to have Dr. Ellgala join us today as our distinguished speaker. And thanks for joining us, Dr. Ellgala. Over to you. Thanks.
Dr. Bora and to the UHC team, thank you very much for inviting me. It's truly an honor, and we had a chance to chat for a few minutes before this started, and it's really nice to meet everybody, and it's nice to get to know you. With that, let me get started. I'm going to share my screen. Before I start, I will say global is where good people go to do good work together. And so I look forward to working with all of you in the future in this. And so this is global neurosurgery. And for those of you who aren't neurosurgeons, I promise this will have some application to your work as well, or your interests. And this is a 20-year journey because even though I'm a neurosurgeon and this talk is about global neurosurgery, the work is really about global health. And so I'm going to digress a little, so bear with me as I talk a little bit about myself. And as Dr. Bora mentioned, just trying to advance the slide. As Dr. Bora mentioned, I really had a wonderful training at the University of Virginia and then at the Brigham and Women's Hospital. And in 2005, when I was finishing up my fellowship, I was really looking at a pretty bright academic future. And, I was on the highway to a chairmanship track in neurosurgery. And the path was set, the course was well identified. Many before me had gone down this road, but I decided to take an alternate path. And literally and figuratively, it was an alternate path that really, there was no roadmap. I had, because of my year in New Zealand, I had done some work in the South Pacific and one of the islands, and I had really gotten interested in helping the developing world to advance healthcare. And so I had an interest in going to Africa. I had never been, and partly for the adventure, partly for the medical experience, I decided to go, and I went to an unmapped area. The place was called Haydom. It's a little village with one of the main referral hospitals in Tanzania at the time. And it's not on this map. There was no road that was paved. There was a dirt track, and where my arrow is pointing is roughly where that hospital was located. And so this is 2006, right after I finished my fellowship, and I got calls from my mentors at the time. And they said, and this was really unheard of at the time, that a young neurosurgeon fresh out of training would do this. And what they said is, Dilan, you're going to ruin your academic career before you even start it. The time to do this is when you are retired. And they were absolutely right. Most of the surgeons, the neurosurgeons that were doing this kind of work, were either retired neurosurgeons or at the tail end of their career, taking time off for a week or two to go do this type of work. And they were right. I actually did ruin my academic career for a long time with this. And and at the time, there was no such thing as global neurosurgery. It was called humanitarian neurosurgery. It was really a traditional medical mission model, except for a few people with FIENS, the Foundation for International Education in Neurosurgery. The vast majority were doing mission model based care. So short-term care provision, flying in and out. It was treatment driven, not training driven. And what I saw when I went to Africa for the first time was that it really perpetuates a cycle of medical dependency, and worse, it perpetuated a cycle of psychological dependency, which had broad standing ramifications. And so this is a map of data from the mid 2000s that shows the patient per doctor ratio. And so in the US, 390 patients or population per doctor. In Africa, it's much worse. In Tanzania, at the time, it was 50,000 patients to one doctor. And the reality is that if you look at the global health workforce and the global disease burden, the disease burden is the lowest where the health workforce is the highest. And that makes sense. You have a lot of, if your GDP or GNI is high and you have wealth to spend on healthcare workers and everything that goes along with it, your disease burden may be less. And in Africa and Southeast Asia, the converse is true. In Tanzania, it was even worse in neurosurgery. So at the time, 20 years ago, there were two neurosurgeons for 43 million people, both of whom were in the capital, in the commercial capital in Dar es Salaam. And outside of the commercial capital, the main referral hospitals often did not even have local Tanzanian medical doctors. It was they're called AMOs, or assistant medical officers, the equivalent of RPAs. And so this is the first hospital that I spent 6 months doing work in, and this is in Haidam in the high plateau of the Rift Valley. And what I saw when I got there is that the Western temporary workers who came for a few weeks or maybe a month or at the most a year were the ones who were sitting in the front of the room doing the work. Then they would go off and do the work. The Tanzanians were off standing on the periphery. And this was really the par for the course at the time. And it perpetuates a cycle of dependency. And so what I thought we should not do or avoid doing is parachuting in, doing the work ourselves. It makes us feel good, but it really leads to out-migration of capable, ambitious, young local clinicians and medical doctors and nurses. And so this is a picture of the first operation we did at Haidam Hospital. And this is Maega. I call him Dr. Maega. He wasn't a doctor at the time. He was basically the equivalent of a PA. Then this is the first and last operation I ever did as the primary neurosurgeon. So he's assisting me. This gentleman is holding a fly swatter and holding the light in place. This gentleman is a nurse anesthetist. He's hand ventilating the patient with a bottle of halothane on a gauze to titrate the anesthesia. And this is every case afterwards. So he's the one doing the case. I and a resident are teaching, and that was the model that we used. And this is probably the hardest thing to do for those of us in Western medicine, is to put our hands behind our backs and observe and teach, even though we know that a patient is probably going to be harmed, that we could have saved if we stepped in and did the work ourselves. But that patient that we saved results in disenfranchisement of the local healthcare worker if we don't do it carefully. And at the time, we weren't. And the goal is then place the responsibility and the care in the hands of our local partners and be there as mentors, advisors, and friends. And so in the first 2 years, 2.5 years, I spent about a year living and working in that hospital, in that village. Maega, the non-MD, taught the first local MD at that hospital, Dr. Nuas. They together taught the next MD at that hospital, Dr. Haite. And these three are still 20 years later at that hospital. Dr. Nuas and Haite are still doing neurosurgery there, or basic neurosurgery. And so the first 6 months, I taught them to do basic brain and spine work. And then they taught each other. And these are some pictures of that time. And we would make our own instruments. We made our own wire saws. Duct tape was very handy. We used camping headlights for light because often the lights went out. Once you took out a brain tumor in this picture, we didn't have any way to stop the bleeding from the tumor margins. So we would cut out needles off the suture, lay them on the bed of the tumor to act as coagulants. So there was a lot of MacGyvering that went on. We would cut plates and screws in the hospital garage, sterilize them to fuse spines for spine fractures. And so I came away from that and thought, this is okay, but we really need to put some organization around it. And I started this nonprofit, Madaktari Africa. Madaktari in Swahili means doctors. So Doctors Africa. And really, my goal was to take mission-based healthcare into the academic world, especially in neurosurgery. And so we built a REDCap-based database. Everything we did, we captured in data. And we published in the first few years of our work, we published extensively on the work that we did. And very specifically, we looked at how do we transfer care, how do we transfer knowledge most efficiently and effectively. So we looked at different models of training. One we call the back-to-back model, where we had experts from the West go for periods of a month or a few weeks at a time, back-to-back to train our local partners, versus a long-term model, one-to-one training, where we sent physicians for 6 months to a year at a time, working one-on-one with the local healthcare partner. And we showed that transfer of knowledge was much more efficient, much more effective, longer lasting, and less costly with the long-term model rather than sending somebody over and over. And so based on this data, we launched the first global neurosurgery fellowship. And we did this in 2011 and 12. And these are US fully trained neurosurgeons who went and spent 6 to 9 months in Tanzania training our local partners because we knew that was the model that worked the best. And so over the first 6 years or so of the work, we coined the term global neurosurgery. Mike Haglin at Duke, Roger Hartle at Cornell, and I at a couple of our meetings, our national meetings. We coined the term global neurosurgery to differentiate this work from the mission-based humanitarian work that was going on before, and really to bring it into the academic milieu. And so we had medical students who kept our outcomes databases, residents who would do the basic training, and fellows, faculty who had oversight and training of the more complex cases. And over the first 5-6 years, we had 14 US universities involved in this work. And as we did this, we realized even more that the problem of equipment was an issue. You couldn't just MacGyver everything. You couldn't just make it from locally available parts. And so Dr. Mohammed Janabi was one of the leading physicians in Tanzania. And over dinner one day, he said, imagine training at the Cordon Bleu in Paris to be a world-class chef, and then coming home to your own house and not having the fancy equipment with the tools and ingredients. It is incredibly frustrating and depressing. You will either stop trying or you'll find a way to go back to Paris. And that was in a nutshell what was happening to the best and brightest of the healthcare workers in Tanzania at the time. And so in order to try and solve this problem, we partnered with Clemson's bioengineering department, and we launched a developing world bioengineering program to produce sustainable devices for the developing world. And at the time in 2010, it was one of only 3 in the US, along with Rice and the University of Washington. And just to give you an example, I know we have some pediatricians in this, neonatologists in this audience, and one of the devices that they made is a warming blanket for premature infants that turned itself on and off because the incubators often stopped working and the babies died overnight. And they made other things in neurosurgery, but also they made glucose strips out of locally available chemicals that could be made in a printer cartridge for less than a penny a strip. And there are many more like that. And so in the first 10 years or so, we went from mission-based humanitarian neurosurgery to a train forward method of training the trainer that we showed worked, and worked not only in neurosurgery, but then we applied it in other medical disciplines. So at one point, we had programs in every single major government-run hospital in the country, not only in neurosurgery, but in primary care, in cardiology, surgery, general surgery, anesthesia, and nursing. And so we brought in the allied healthcare team, nursing, biotech engineers, physical therapists, et cetera. And really, this became global neurosurgery as an academic endeavor. And then launched the Developing World Bioengineering Program. So from 2014 to 2019, I took a pause. So all this time, I've been funding this basically out of my own back pocket, doing it on the cheap. This is actually one way I saved on costs when I was traveling in Tanzania from hospital to hospital by camping out in the bush in between hospitals. And that's not really a sustainable way to grow something. And so I took time to become a little bit more financially independent. And then in 2019, 20, 21, I approached the Barrow Neurologic Institute, which for those of you not in neurosurgery may not know, it's the largest neurosurgery residency program in the country, one of, if not the largest neurosurgery program. They do 10 to 12,000 operations a year here, 28 residents, 5, 6 fellows, and they're extremely well funded. And so the Franke family, Bill and Carolyn Franke, invested and endowed a global neuroscience education program. They gave $21 million. And at this point, as far as I'm aware, it's the largest global surgery endowment in the US, much less global neurosurgery. And so we officially launched this program in 2022 in January. We were the third division of global neurosurgery in the US. And I think already we're one of, if not the largest global neurosurgery programs in the country. And so we now have 3 fellows, US neurosurgery, global neurosurgery fellows that spend time with us in Phoenix at the BNI and then go overseas for 9 months to get global neurosurgery hands-on experience. Because I think unless you really immersed yourself in the field, it's hard to truly understand the nuances of global health. We have 2 research fellowships for international neurosurgeons to come here and learn how to do research, to take back with them, to develop academic neurosurgery programs of their own. We have funded observerships for clinicians from underrepresented countries to come and see how we do things here and maybe learn a few things and vice versa, to elevate the care locally. And the next phase of this, so we've shown how we can increase the healthcare workforce in the most efficient manner, in the most effective manner. But how do we do this in a more sustainable way? Because what I saw as I was doing the work and living, so over the last 20 years, I probably lived and worked for about 4 years in East Africa, is that as we put in subspecialty care, for example, Madaktari Africa has been involved in developing the cardiac center in Tanzania called JKCI. And it's one of the leading cardiac centers in sub-Saharan Africa now. But what I've saw is that the cost of high-end specialty work is incredibly expensive and could be bankrupting the ministries of health. So what is the solution to that problem so that we're not taking resources away from primary and preventative care? And so even back in 2010, we were presenting on the economic impact of the work we're doing. What happens when you elevate the number of trained healthcare workers to the economy of the country that we're working in? And so the latest work that we're engaged in with the Thunderbird School of Global Management at Arizona State University is what is the impact of introducing subspecialty care? So we're looking at gross national income of a country and its ability to sustain high-end specialty care, and high-end often means high cost. And as an example, we're looking at cerebral aneurysm care. So there's two ways to treat aneurysms. One is with endovascular coiling. The other is with open surgical clipping. Endovascular coils are expensive. Open surgical clipping requires a longer stay in the hospital. So in the US, it's roughly equal. It's about $41,000 to $45,000 per episode of care. And we're looking at what is the cost in a place like Tanzania. We're also looking at other countries like Paraguay and Panama, two of our other partnering countries. And I'll give you the brief results. This is not yet published. We're actually in the process of writing this up. And so the study is looking at what is the financial impact of introducing high-end specialty care in a lower income country. And the hypothesis is that the cost of the consumables sourced from high-income countries or middle-income countries will be the primary factor in determining economic sustainability. And what we're finding is that the cost of doing nothing, so letting the patient have an aneurysm and potentially have a ruptured aneurysm, is very high in terms of the gross national income and the impact to GNI in the country. So just to give you an example, we estimate that it would cost about $280 million per year to the country of Tanzania if their aneurysms were never treated. The entire Ministry of Health's budget for last year was about 400 million. So you probably do need to treat, but how do you treat? And what we're seeing is that the GNI will either have to rise or the consumable costs will have to decrease in order for specialty care to be affordable in these countries, or both need to happen at the same time. And so how do we do that? Do we wait for the economic development of the country to occur? And my answer is probably not. I don't think we can afford to let patients suffer and die during this time. And one way to alleviate this is we're looking currently at regional assembly or manufacturing of devices and consumables, and we are in early discussions with interested Western manufacturers. And what this could do, whether it's an assembly plant or actual manufacturing plant, is to help develop a medtech economy for the region, which elevates the GNI, and it can lower the overall cost of healthcare so that the Ministry of Health's budget isn't decimated. And it also allows us in the global health community to plan better, because I've seen over the last 20 years where we've tried to go in and put in high-end specialty care, dialysis care in a country like Tanzania, for example, um, and mitral valve replacements, things like that, where the training has been successful, but the programs have not because the funding isn't there to sustain them. So tying in when to go in with which specialty, we also need to think about the economic impact to the country as a whole, because if we're taking away from primary and preventative care, we may be doing more harm than good. So phase zero of this journey has been taking humanitarian mission-based neurosurgery and bringing it into the academic milieu. So clinical capacity building and independence. We now have two neurosurgery residency programs in Tanzania that we've helped to start. The second one just started last year and took a resident from Kenya and one from Tanzania. One of the residents from the other program is with us currently at the BNI as a funded observer. He's learning how to do research, and he's about to launch a major research initiative when he gets back home. The phase two is now looking at the economic sustainability of advancing healthcare. And this is in partnership with a major business school here in the US. And then training and research. So the Frankie funding is helping to train our partners in how to do appropriate research with the resources available in their home institution. And the goal is to culminate in the establishment of academic neurosurgery in the developing world for the developing world. So we've I think been successful as my colleagues in global neurosurgery in the U.S. and having global neurosurgery become an academic endeavor in the U.S. We also want to have academic neurosurgery now in sub-Saharan Africa in some of the countries that we're working with. And this is an example, I think, of the success of some of these programs. We've had 22 manuscripts just in the last 5 years, 13 projects that are submitted or in preparation, 20 more projects in the pipeline, and all of these projects have multiple authors who are either from Tanzania or other parts of the developing world that are our partners. And it's really moving all of us worldwide into academic neurosurgery and hopefully changing what we know and how we do things. And I'm going to end with the critical part. You know, to do this kind of work, you really need support at the highest levels. And so none of this really would have been possible at the rate that we've been able to do it without support from the president of Tanzania. And so this is President Kikwete, one of the two presidents ago. He was a major supporter of these programs. We've met with him every time we went to Tanzania to give an update. And you really need this either at the president's level or the minister of health's level to do this in an efficient and effective manner. And currently, Dr. Janabi, who is a longstanding colleague and someone we've collaborated with, is now the World Health Organization's director for Africa. And he sees the potential of what we're trying to do, which is not just train, but also look at the spectrum of healthcare and how do we make this sustainable in a financial model as well. And so this is I'm making this a shorter talk so that we have time to discuss more. But you know, my whole goal when I started this 20 years ago is really to make more of an impact, to make an impact in my field in academic neurosurgery, to make more of an impact in the world around me, and really to follow a passion. I'm a product of the developing world. My family comes from South Asia. I've benefited from being in the United States and everything that the Western world has to offer. And this is a bit of how I can give back to the US, but also to my colleagues around the world. And so with that, I'd like to thank you for taking this time and would be happy to answer questions and have a discussion about this.
Thank you, Dr. Ellgala, for a wonderful talk, for sharing your journey of how to take mission-based work, training local physicians and surgeons to really creating this whole field of global neurosurgery. Just a reminder for our attendees, if you have any questions, please type them in the Q&A box. And with that, I will just start with a question. You ended that you wanted to make an impact. And if you have this, look at this work of 20 years, what do you think has been your biggest impact on the field?
You know, it's the next generation. So Carrie Vaughn, who was our first global neurosurgery fellow at the BNI, is now the first global neurosurgery faculty member at the BNI. And you know, she's going to be one of the leading lights in global neurosurgery over the next 20 years. The young Tanzanians, the young Paraguayans, the young Panamanians, the young Argentinians who have worked with us, I'm sure are going to be leaders in the field back home in their countries as they go through the next few years. I would say the next generation is it. And then the other part of this is because of the political connections, we were able to have Haydn Hospital, which is the main hospital for 5 to 7 million pastoralists in remote Tanzania, and they were about to lose their funding, and we were able to have the government of Tanzania come in and make it a government shared hospital and fund that. And so they're still doing well, taking care of all those patients. So I would say those are the two things I'm most proud of.
Thank you. And we have a question here in the Q&A box. Um, so it's about how do you see the use of AI for healthcare in low resource settings? And our colleague Esther was listening to a story this morning on NPR about AI-enabled radiology, diagnosed TB in Africa where no radiologists are available.
Yeah, I think that's a great question, and absolutely the future. So we could spend the next 20 years training people, building hospitals, clinics, laboratories, and with the population growth in the developing world, so Tanzania, as an example, is 43 million 20 years ago, 65 million now, projected to be 150 million by 2050. There's no way. The estimate is you would have to spend $2 billion to build enough hospitals, train enough people to take care of that population. There's no way we're going to be able to do that. And the solution is with technology. And I think AI-based diagnostics, the radiology diagnosis that you mentioned, we're actually working with a company called Advisor Now, for they do AI-based medical diagnostics or decision making that will uh, increase the ability of one clinician in rural Tanzania or rural developing world to make accurate diagnosis using smartphones and web-based technology. So I think that is the future. I think we need to embrace that. Some of the regulations that occur in the US that limit the use of AI in healthcare currently don't exist in the developing world. So there's an opportunity to really change how healthcare is being done and leapfrog the US. So just like Sub-Saharan Africa went from no telephones to cell phones and skip landlines, I think in healthcare, Sub-Saharan Africa has a chance to leapfrog some of the regulations and corporatization of healthcare to make healthcare available at low cost to the public. And I think technology with AI is the way to go.
Thanks. Just going back to your presentation where you mentioned about 14 or so institutions coming together initially for, global health is a very crowded space, and occasionally it's very difficult to navigate. At least that has been my experience. So I was wondering, how did you bring all of these partners, or for lack of better word, competing institutions to come together and buy into your shared vision for something that is quite niche?
Yeah, I think it has to do with the people who are interested in global health. You know, by and large, it's not about our own egos or about our institutions. It's about doing something better. Um, and I will tell you, in my specialty in neurosurgery, if I look at tumor neurosurgery, we're all competing with one another. But on the global space, we tend to partner rather than compete. And we 20 years ago, there was a small group of us interested in this, and we all got together in a meeting room in St. Louis in 2007 and said, let's work together to do this. And we've all stayed in touch. Mike Haglund, who's the director of global neurosurgery at Duke University, is an adjunct faculty with us. We hold joint conferences together. I think part of it has to do with the types of people who are doing this kind of work. The other part is, there's something bigger at play here than individual institutions. And there's too much work for one institution to do.
So thanks. So really finding like-minded people who share the same passion and vision, and having the buy-in of your institutions. I also saw you shared this 3 phases. First is clinical capacity building, economic stabilization, and third one was research. And was there a reason for this phase development? So why was clinical and research not built up at the same time? And
That's a
yeah.
that's a great question. And actually, in reality, they were. So this went concurrently. The clinical work and the research all went at the same time. The difference in that third phase is we were doing the research. So US med students were collecting the data. US residents were writing it up with US faculty and partnered with our local colleagues. Here in this phase, what we're doing is it's the local students collecting the data. It's the local residents helping to write and initiate the projects, and it's local faculty who are leading. And so we just didn't have the funding to fund our colleagues overseas to do the work or come here to train to do the work and go back. And it really required the Frankie family's endowment to give us the financial freedom to do that. And we wouldn't have been really able to otherwise.
Thank you. And just for the panelists as well, if you would like to ask any questions, please unmute yourselves. And for the rest of the attendees, you can type in the Q&A box. And what do you think, how has the field changed in the last 20 years, not just global neurosurgery, but global health in general, just in the last 20 years?
But I think a big part of it is, when I started, nobody wanted me. When I reached out to the global health organizations to volunteer, they said, we don't need neurosurgery. We need infectious disease, emergency medicine. And so a big part of the change in the early years was the recognition of non-communicable disease as a burden of healthcare in the developing world, and getting general surgery and everybody else involved. So that was a major change. The other is that this is really a recognized part of academic neurosurgery. When this really wasn't outside of infectious disease and emergency medicine. It wasn't really part of academic medicine, and that's changed dramatically. And then what I'm seeing now is the importance of bringing in other disciplines, the economics of global health, technology, the entire team, not just the physicians, and not just nurses, but also biotech engineers and others that are vital here in our hospitals and are elsewhere in the world as well. So I think those are the big changes I've seen, and the interest in the next generation. And every medical student I talk to has an interest in at least getting exposure to it.
Thanks. And do you think that, it's really in the US, or the field in general, this global neurosurgery, you have seen the surge in other countries as well, or is it really concentrated in the US?
No, I think it's everywhere now. So the Europeans were doing it at the same time as we were. But what I'm seeing now is, for example, in Tanzania, are we really needed? And the answer is no. It's nice that we're still wanted, and there are things that we can do together, but we're now more of an equal playing field. We're just colleagues learning from one another. And I'm seeing that around the world. So in our Latin American partnerships, some of what they're doing in Panama is more advanced than what we're doing here. Our Paraguayan colleagues are doing fetal myelomeningocele repair, which isn't being done in Phoenix, Arizona. And they're about to go train the Tanzanians in those techniques. So what I'm seeing global neurosurgery being is a community of like-minded people sharing our knowledge and expertise back and forth. And that's really where we wanted to be.
Thank you so much. That's a great note to end this session. This was truly an inspiring presentation, and really gives us a lot of hope. We have many young students and trainees joining us today, so I think it really gives us hope on what can we do when we set our mind to change something. With that, I'd really like to thank you for your time, for your sharing your story and giving us some very powerful insights. Thanks to all the attendees who joined us today. And for those of you who are invited to the meet and greet, please stay online, and we'll transition to that session in a few minutes. Thanks.
Thank you very much.
Let us know. I think we are good, right? Yeah. Right. So we have three faculties here, and one of our very young student, I think Maddie is an aspiring neurosurgeon who came to us as a summer scholar and has stayed with us. So I thought generally, well, we only invite faculties, but I thought Maddie will enjoy joining us here. And we have Shubham, Rachel, and Bianca. And Rachel, do you have any connection with Tanzania as well through Andrew?
Yeah, I do actually.